So I'm going to start now to introduce our first speaker for this morning. And our first speaker is Darcy Wooten from University of California, San Diego. She's a professor of medicine in our Division of Infectious Diseases and Global Public Health. She did her undergraduate studies at Stanford University, completed medical school in internal medicine training at UCSF, and her fellowship at Harbor-UCLA. So she knows a lot of the faculty who are here and has been one of our principal colleagues in HIV medicine. She currently serves as our infectious disease fellowship program director and a course director for clinical reasoning, something that medical students really need for second-year medical students at UCSD. And she also serves as the vice chair of the Medical Education Executive Committee for the IDSA's Medical Education Community of Practice. And Darcy's going to talk to us about the state of the art for hot antiretroviral updates from CROI and beyond. So, Darcy, welcome.
Here's your great. Thank you. Well, welcome. So glad to see everybody here and very excited to talk to you about some really hot and interesting updates on antiretroviral therapy. Most of what I'll be talking about was presented at CROI. Here are my financial disclosures. And here are the learning objectives and the things that we'll be covering. So we'll spend the bulk of the time really talking a lot about long-acting antiretrovirals because there's just so much happening in this space and lots of really new and exciting updates. I'll touch a little bit on antiretrovirals and weight gain, and then finally finish up with antiretrovirals and some new updates in pregnancy. So we'll start with updates on newer antiretrovirals, and to begin with, we're going to focus on long-acting rilpivirine. And I just wanted to kick it off with an audience response question, just sort of seeing what proportion of your patients are currently receiving long-acting rilpivirine for HIV treatment. So go ahead and you can use the QR code or the website with the code there to select your answer. All right, give it another couple seconds or so. So it looks like a pretty good mix. Some people using it more than others, and so I think we'll provide some updates on long-acting rilpivirine in newer populations. So as you're all aware, rilpivirine has been available for several years now. It was initially FDA approved as a switch regimen in patients who are virologically suppressed, and because of its long-acting formulation, it can be given as an injection every 4 weeks or every 8 weeks. It is needed to be given in a clinic by a healthcare professional. It's not approved for self-administration at home. And there are a small number of contraindications based on how the initial studies were designed, the ATLAS-FLAIR and ATLAS-2M studies, in terms of certain criteria that you'd want to avoid using this regimen for. And those are if you have resistance to rilpivirine, if you have a history of prior virologic failure, and this is sort of a softer indication, I would say. Definitely pregnancy. There was a recent case report in CID where PK levels in the 3rd trimester for the rilpivirine with this regimen were quite low. And then this regimen, remember, doesn't have activity against hepatitis B, so if you have a patient with co-infection, they would not have active agent against HBV, and they need to be on something like entecavir. But this is a really great and newer option for our patients. Like all regimens, but with long-acting in particular, we do worry about and think about virologic failure because this regimen is not like boosted protease inhibitors or our second-generation INSTIs in terms of having a really high genetic barrier to resistance. So looking at virologic failure is something we keep our eye on pretty closely because if people do develop failure, they can develop resistance. And so Orkin and colleagues have looked retrospectively retrospectively from the original randomized controlled trials to see what are the predictors, what are the risk factors that could increase the risk for developing virologic failure. And the things that sort of shake out in that analysis are listed here. So definitely having baseline rilpivirine resistance mutations is probably the risk factor that puts you at the highest risk for virologic failure. And then also it was identified that infection with subtype A1 or A6 slightly increased your risk, as well as elevated BMI. And really, if you had multiple of these risk factors, that was the most substantial in terms of increasing your risk for virologic failure. So these were from the clinical trials, but then how does this regimen do in the real world now that it's been approved in terms of virologic failure? So these were some cohort or observational studies that were updated and presented at CROI looking at real-world outcomes with rilpivirine in terms of virologic failure. And you can see in the sort of peach color, the rate of virologic failure from all of the randomized controlled trials is about 1.2%. And when we look at these big multi-site cohort studies throughout the US, like the OPERA cohort, the TRIO cohort, you can see that rates of virologic failure are pretty similar to what we saw in the randomized trials. There was a newer cohort that you are probably familiar with, a Chicago cohort that was a little bit smaller, but the rate of virologic failure in this cohort was slightly higher. 3 out of the 75 individuals experienced failure. And when they went back and looked, 2 of the individuals had been receiving their injection at an infusion center where it was identified that the injection technique wasn't correct or precise and probably led to or contributed to some of the virologic failure there. But overall, in real-world practice, this regimen looks fairly good compared to the randomized controlled trials. So what I want to move on to now is looking at rilpivirine in sort of newer populations where we haven't been using this before, and present some updates and new data that was presented at CROI, starting with the CARE study, which is looking at long-acting rilpivirine in southern Africa. So this trial was designed fairly similar to the IAS-2M study, in which patients who were virologically suppressed on an oral regimen, and the vast majority of them were on a dolutegravir plus 2 nuke-containing regimen and had no history of treatment failure, were randomized to either switch to rilpivirine given as an injectable every 8 weeks or to continue their oral therapy. And they looked at outcomes at week 48. Now, what was different in this study is that they used a public health or sort of standard of care approach in terms of monitoring viral load. So they only checked the viral load every 24 weeks. So on the left, you see baseline characteristics of the population, and I want to just highlight a few things because it becomes important when we talk about sort of how we think about risk factors for virologic failure, and our thinking on this has changed. So you can see a relatively high proportion of individuals in this group had an elevated BMI greater than 30, and then over half had infection with subtype A1. Not surprisingly, 3/4 had NNRTI exposure. And then the investigators at baseline collected PBMCs and did archived resistance testing. They didn't have the baseline archived resistance results at the time of randomization, but when they went back and looked, there's actually a fairly high rate of archived resistance, 10% for rilpivirine and 8% for cabotegravir. In terms of outcomes at week 48, you can see excellent outcomes, very similar to what we saw in ATLAS-FLAIR and ATLAS-2M, 97% of patients virologically suppressed in both groups. There was 1 patient in the rilpivirine group who did experience virologic failure. So really great, exciting results, I think, and I think some of the take-homes from this, we've really demonstrated rilpivirine can be used in places like low and middle income countries very effectively. I think our thinking about whether or not A1 subtype and elevated BMI increases the risk of virologic failure is probably less of a concern, and probably in those original studies it was really the A6 subtype that was driving that. The question about if a patient has baseline rilpivirine resistance or there's concern about that, can we use this regimen? I think I definitely would be very anxious and would not recommend that. I think the guidelines would support that as well. Again, this isn't a regimen that has a high genetic barrier to resistance, so I think that's still something that we need more data on and would avoid at this point because of that risk of developing resistance with failure if there is baseline resistance. So another patient population that it makes a lot of sense to think about long-acting therapy is in adolescents. And so this study was the MOCA trial, which was a phase 2 study looking at the use of cabrolpivirine in individuals who are virologically suppressed, ages 12 to 18. And this wasn't a controlled trial, it was an open-label trial, so everybody was switched to long-acting cabrolpivirine given every 8 weeks, and this was following an oral lead-in. And then because it was a phase 2 study, the primary outcome was safety, but they also looked at virologic metrics for their secondary outcomes. In terms of safety, like we've seen in adults, cabrolpivirine was very well tolerated. We know that injection site reactions can happen, but they tend to be pretty mild, and there weren't any permanent discontinuations. And then you can see rates of virologic suppression were outstanding, with 97% maintaining virologic suppression at week 24. And then the last group where we think long-acting therapy makes a lot of sense and can be really beneficial is for individuals who have just really struggled and have significant barriers to daily oral antiretroviral therapy. And so these were the results of the Latitude trial, which was probably one of the biggest and most exciting data that were presented at CROI, looking at cabrolpivirine in this specific group. So this was an open-label phase 3 study in which patients had to meet criteria for having barriers to adherence, including having either a poor viral response to oral therapy for 6 months or being lost to follow-up. Patients with rilpivirine or INSTI resistance were excluded, and then they couldn't have hepatitis B. So in this study, in the step 1 portion of it, all of the participants were really incentivized to try and get suppressed on their oral therapy, including economic incentives. And if patients were able to get a viral load less than 200, they then went on to be randomized to either receive cabrolpivirine or to continue their oral therapy. And you can see at the time of initiation of cabrolpivirine, actually 17% had viremia, so they had gotten to less than 200, but not surprisingly, if this is a group that struggles with adherence to oral therapy, there were patients who had viremia at the time of starting their injectable therapy, some with quite high viral loads. So the primary outcome was this composite outcome of treatment failure, and then secondary outcomes looked at the individual specific virologic failures and other metrics there. So in terms of the primary outcome, there wasn't a statistically significant difference between those receiving cabrolpivirine versus continuing on their oral therapy. But in terms of the secondary outcomes of virologic failure and treatment-related failure, what you can see is those who were receiving injectable therapy did significantly better, such that the Data Safety and Monitoring Board actually had to stop the study early because of superior efficacy in the injectable cabrolpivirine group, and said you have to offer this to everybody in the trial. So a really amazing and exciting result. I don't think surprising because, again, this study cohort included people who really struggled with daily oral therapy. There were 6 patients in the cabrolpivirine arm who developed virologic failure. 2 of them had resistance, and the resistance was pretty significant, INSTI and NNRTI, but 4 did not. So I think really very much a game changer in terms of clinical practice, and we'll get to that in a second. And this really concurs with data that we've seen from observational studies of using cabrolpivirine in patients who struggle with daily oral therapy who are viremic at the time of starting injectable therapy. And this just summarizes kind of the 3 big cohorts that have been published. There were updates from the Ward 86 demonstration project in San Francisco, where they had 59 individuals, really from a patient population with a lot of barriers to care, 80% with housing insecurity, 70% was substance use, and quite high viral loads at the time that injectable therapy was initiated. And at week 48, 93% of these individuals from the Ward 86 project were suppressed either on cabrolpivirine or another therapy if they had to get switched to a different regimen. 81% were suppressed on cabrolpivirine. So with all of this together, on March 1st, we saw this really important update from on the guidelines panel in terms of when we can think about considering cabrylpivirine in patients who struggle with daily oral adherence to therapy and who might be viremic. Because this is not for everybody who is currently viremic, but for a very select group of individuals meeting the following criteria. So the guidelines say that if patients are unable to take oral therapy after you've really exhausted sort of all options to support them in taking daily oral ART, also if they're at high risk for progression of an advanced HIV disease, such as low CD4 cell count, they do need to have susceptible virus to rilpivirine and cabotegravir, and then ongoing intensive case management and follow-up. You want to make sure patients get to their clinic visits and receive their injections on time. Then we can consider using cabrylpivirine in this group specifically. So really very much a game changer, really exciting to see. So with that, we'll try and apply some of that information to this audience response question. So you're seeing a patient who has had significant barriers to adherence to daily oral therapy, and they've been off meds for the past 6 months. Patient's been enrolled in numerous case management services to try to optimize adherence, but without success. His current CD4 cell count is 134, and he's interested in long-acting cabrylpivirine. So with all of that, which of the following would be a contraindication to starting long-acting cabrylpivirine in this patient? So would it be a contraindication if his BMI was greater than 30, a contraindication if his viral load was greater than 5,000, if he has rilpivirine resistance mutations, or if he has infection with subtype A1? Go ahead and vote. We'll give it another couple seconds. All right, excellent work, over 90% correct. So as we sort of learned from the CARE study, subtype A1, elevated BMI, probably less of a concern. And then really having a viral load of greater than 5,000 from both observational studies as well as in latitude, these patients were still able to achieve virologic suppression. But again, it's having that baseline rilpivirine resistance where we really want to maybe avoid this regimen because of the risk of failure. So great job, everybody. Okay, so we'll switch gears and talk about another long-acting injectable agent, lenacapavir. This is a long-acting capsid inhibitor that was recently FDA approved for really heavily treatment-experienced individuals based on results of the Capella study in conjunction with an optimized background regimen. So basically patients with a lot of resistance where they might not even have any active agents in their oral therapy. And what's really cool about this is it can be given sub-Q every 6 months, but they're also developing an oral formulation that can be given daily as well as weekly, which I'll touch on in just a second. Injection site reactions can occur, and the one that I wanted to bring your attention to were these nodules that can develop because they can persist for a while, and patients are not particularly happy about that, but they still like the regimen, and sometimes this is their only agent that they can add to have an active regimen. So there are a couple studies with lenacapavir that I wanted to highlight from CROI. The first is this case series using an off-label combination of cabotegravir plus lenacapavir with or without rilpivirine. And this was a case series. Our site was included as one of those in the study. And the reason for using this off-label combination of injectable therapy in this cohort was that most of the patients, 60% or so, had NNRTI resistance or concern for NNRTI resistance such that using cabrylpivirine most likely wouldn't be effective. And so you can see the outcomes in terms of virologic suppression before starting this regimen, which is about 47%, and then once the patients were on cab with lenacapavir, rates of suppression up to 94%. So kind of a proof of concept that this regimen might be good for patients with NNRTI resistance who have barriers to daily oral therapy. The other lenacapavir study I wanted to highlight was the Artistry-1 trial, which was a switch study. So this was a phase 2 randomized controlled trial of patients who were on a complex antiretroviral regimen, and they were either randomized to continue their current therapy or switch to a daily oral combination of bictegravir with lenacapavir at 2 different doses. And these were the week 24 data that we're seeing, and you can see rates of virologic suppression were quite high among all of the groups. groups, and so this is moving forward as a phase 3 switch study. So this, if this looks good in the phase 3, might be another 2-drug agent that's a nuke-sparing agent that might be approved, and I think that's exciting, but I think what's even more exciting is the potential for this to go on to be a long-acting injectable regimen with the development of long-acting bictegravir that in theory could be given every 6 months, and wouldn't that be just the holy grail of a high-barrier regimen you get twice a year, and that's kind of it. So very far away from being ready for prime time, but I just wanted to put that out there and get you excited about that potential, because I think this would be a great option for many of our patients if the data look good. The other newer agent I wanted to mention was islatravir. So this is a long-acting nucleoside reverse transcriptase translocation inhibitor, not currently approved, but in experimental studies as a combination with doravirine as well as individually with other agents. And you'll probably remember from the earlier studies that higher doses were associated with lymphopenia, and so these trials were paused and then resumed with lower doses. So a couple of updates from CROI with islatravir is this weekly oral regimen of islatravir plus lenacapavir. And I think this idea of an oral weekly regimen makes a lot of sense. Some of my patients do not like needles, so long-acting cabrolpivirine is not an option for them, or they have trouble getting to clinic every 2 months, and so this gives them a little bit more autonomy in terms of taking a long-acting regimen. So this is a nice option to think about moving forward. This was just a phase 2 switch study of patients who are virologically suppressed on BF-TAF. They did have to have a certain CD4 and absolute lymphocyte thresholds in order to enroll because of the known side effects with the lymphopenia and the islatravir. So they were randomized to either continue their current regimen or switch over to the weekly oral islatravir and lenacapavir. And again, just a small study, and we're following this out. This is just the week 24 data, but rates of virologic suppression were outstanding in both groups, and there wasn't a significant concern in terms of absolute lymphocyte count and impact from islatravir. There are also a couple of other studies that I'll just mention but won't describe, looking at a weekly oral formulation for an INSTI as well as another NRTTI. So lots coming in terms of oral weekly therapy as well. So now we'll switch gears and talk about weight gain and antiretrovirals, and we'll hear a little bit more about this later this afternoon, but I just wanted to touch on a couple of summary points. So we've been talking about antiretrovirals and weight gain and whether or not they contribute to weight gain and how much for several years now, and I think it's still very much an unanswered question. There's been these observations that second-generation integrase inhibitors, especially when compared to things like efavirenz, such as in the advanced trial, which is shown in the upper right, tend to be associated or look like they're associated with more weight gain compared to the comparator. The challenge in interpreting these studies, though, is that the comparator regimen might be something that is actually mitigating weight, and how to really tease all of this out, I think, remains sort of somewhat unanswered. And then you also have to take into account the significant virologic benefits with second-generation INSTIs. I think a question that comes up all the time is if a patient does gain weight on a second-generation INSTI, does switching them off of that regimen to something else actually change that weight gain, stabilize the weight gain, or actually lead to weight loss? I'm not going to go through all of these trials, but this is just a summary table showing that when you switch off of an INSTI to either a 2-drug regimen or a regimen that doesn't contain an INSTI, it doesn't have an impact on weight, unfortunately. So switching off for weight purposes isn't going to lead to the effect, at least in these studies. We are still waiting the results of the DO-IT trial, which is patients who are on an INSTI-containing regimen, and then they get randomized to either doravirine or to continue their current regimen. And maybe we'll see weight differences there, but based on the results of these, I'm not particularly optimistic, but that's still pending. The one switch that we know does really impact weight is when patients switch off of TDF to TAF, and that seems to be very well documented. We also see the converse of that. So these are the results from the characterized study, which was a follow-up of the advanced trial, which, as you'll remember, the advanced trial had 3 different arms: dolutegravir FTC TAF, dolutegravir FTC TDF, and efavirenz FTC TDF. Those in the dolutegravir TAF group had the most weight gain, and then the characterized study, everybody was switched to dolutegravir, lamivudine, and TDF, and you can see the ones that were on dolutegravir plus TAF when they got switched to TDF had weight loss, particularly women. So we do know that the converse is true when you go from TAF to TDF. There is some weight loss. And people have tried to kind of get at what is the mechanism by which TDF maybe is impacting weight, as well as this well-described impact on lipids. And so this was a mechanistic study presented at CROI, in which they took 12 individuals who are on a TAF-containing regimen and 12 individuals on a TDF-containing regimen. They did EGD with biopsy, and based on how the pathology looked, they hypothesized that maybe TDF is impairing absorption, and that's how it's having its impact on weight as well as lipids potentially. Very small numbers. Some of the differences between these groups weren't statistically significant, so I think hypothesis generating only, but interesting nonetheless in terms of impact on TDF on weight and lipids. So now we will just wrap up and talk about very briefly some updates in pregnancy and antiretrovirals. And the thing that I wanted to highlight or draw your attention to was this change or update that came in January of this year with the perinatal guidelines. So the key differences were that boosted darunavir, which used to be a preferred agent, and then bictegravir, which was categorized as having insufficient data for pregnancy. The big change here was that boosted darunavir moved to an alternative agent, and then bictegravir moved up as an alternative agent because we got more data on it. And that is what I'm going to present next. So this was a PK study that was published in AIDS earlier this year. It was an open-label study of 33 pregnant individuals who were receiving BF-TAF, and they looked at bictegravir levels second trimester, third trimester, and then postpartum. So the top pink and purple lines show the postpartum levels of bictegravir, which are higher than the second and third trimester levels, which are in the blue and red further down. But the point that I want to make is that all of the levels throughout all of these different phases of pregnancy and postpartum were well above the therapeutic or target thresholds that one would need to achieve in order to maintain virologic suppression. So the levels, even though they do drop in the second and third trimester, stay well above where we want them to be. And concurrently, 100% of these individuals remain virologically suppressed, and there were no neonatal transmissions. So really nice PK modeling or study showing BF-TAF in pregnancy. And this corresponds to a recent study that was observational study that was published in CID just last month from 4 US sites of about 150 individuals who had received a bictegravir-containing regimen at any point in their pregnancy. Most of the individuals in this study were on BF-TAF and then became pregnant and continued during their pregnancy. Others were diagnosed with HIV when they presented for pregnancy and then were started on BF-TAF. Regardless of the group, the rate of virologic suppression was quite high, 90%. And in terms of outcomes such as preterm labor, congenital malformations, the numbers are really too small to draw any significant conclusions, but these look to be what we would expect, but really need more data on this. There was one perinatal transmission in an individual who was on BF-TAF. This was somebody who had acute HIV during week 31 of their pregnancy and then got started on BF-TAF, so probably an effect of having a very high viral load in the third trimester that contributed to that perinatal outcome. So with that, the FDA expanded the label for BF-TAF in pregnancy, and this was just in April, and again, that concurs with bictegravir now being listed as an alternative agent in pregnancy. So I will just wrap up and kind of summarize the things that we've talked about in terms of take-homes for newer antiretrovirals. We've talked a lot about long-acting cabrylpivirine and kind of new populations where it hasn't been used before, including in low and middle-income countries, adolescents, and then patients who struggle with daily oral therapy and have viremia. We also briefly talked about lenacapavir and islatravir and some exciting developments there. In terms of antiretroviral and weight gain, really what we're seeing is that switches don't help. The one exception is TAF to TDF, but really at what cost? Just keeping in mind the known bone and renal toxicity, especially over long periods of time. And in terms of antiretrovirals and pregnancy updates, really the big exciting news is that bictegravir is now considered an alternative agent with an FDA label. So with that, I will thank you for your attention, and I'm happy to take questions.
So as you can see, there are some microphones in the audience if you want to come to the microphone and ask questions. And I'm going to start with a few that have come in through our Q&A through Slido. The first of these is, what are your thoughts on using cabrilpivirine with very low level or only possible resistance?
I think for that, I would really sort of individualize it. I would be a little bit anxious to do that, and I'd want to kind of go back and look at all the genotype data, all the treatment regimens, and sort of see, could there be underlying, or could there be resistance mutations that maybe are there that we don't know about or that we're not identifying on our test? So I'd be somewhat cautious about that. If that was sort of really the only good option that was available and that the patient was sort of willing to take, then I might consider it, but I would be a little bit anxious to do so. Would it work? Probably, but we have a lot of really good alternative options and other agents to use, including potentially lenacapavir, but couldn't do an entire regimen with injectables there in theory. So I would be a little bit cautious and again, look for other options.
Great, thank you. Another question also related to cabrilpivirine. Are there specific IM techniques that you should be aware of when you're prescribing cabrilpivirine and providing instruction about?
There are, and I am not the person to ask about them because I don't administer, but it is important to make sure that whoever's administering the cabrilpivirine is using the proper technique. The one thing that I'll say is that if you do have individuals who have elevated BMI, using the longer 2-inch needles is definitely important. I think that can be tricky because they don't necessarily come in the kit with the medication, so making sure your clinics are sort of set up to have that, and then have everyone who's giving the injections have the appropriate training and experience as well. I know I have patients who come in and ask for particular nurses to give them their injections because that nurse always does it how they would like it to be done. And so making sure you kind of have all of those things in place and have that training in place.
And I know we have nurses and pharmacists in the audience, so if any of you are the persons charged with providing the injections and have any insights into this, please feel free to comment at the microphone, if you will. Yes. That microphone is set for a giant 7-foot-tall person, I think.
I just have one question. So after going through, 3 times a day therapy or 4 times a day therapy to twice a day to once a day, and showing that once a day really does make a big difference, and it's quite understandable how once a month or once every 2 months would make a big difference. But in terms of giving pills every week, in a clinical study, there are people that call and remind patients to take pills. Are there any other situations or any clinical experience on whether people really remember to take once-a-week pills? And are there any significant medical conditions where once-a-week therapy is used and we know what adherence is? And also, what's if someone is 2 days late, is that okay?
I think that's an outstanding question and definitely something that we're kind of grappling with, and I think probably each clinic and each center is going to have to come up with strategies, because that is a big difference between self-administration, right, and then in-clinic administration. We know when patients miss their injection or are late to their injections, but we're not necessarily going to be able to track everybody on weekly oral therapy. So there's definitely strategies out there, and GLP-1 receptor agonists, which are patient-administered, which are weekly therapies, there is precedent as one example, but I think it is something that we're thinking about and are worried about. In terms of sort of time frame of, can you be 1 day late or how many days late? I think that's still TBD, but important to think about and get that data, and then to know kind of what what measures are going to be in place to make sure that you're reminding patients and ensuring that they're taking it. I think also, for weekly LTBI therapy is another example, and do we implement, sort of DOT or text messages to patients? I think there's probably a variety of strategies that need to be studied, but a really, really important point, especially if the regimen doesn't have a high barrier to resistance and isn't as forgiving if you are late and or miss doses. So really important point. Thank you.
So the next couple of questions are related to lenacapavir, one of the other longer-acting agents you talked about. And the first is from one of our esteemed pharmacists in the audience. So commenting about new concerns related to drug interactions with some of the longer-acting agents, including lenacapavir. An example he cites is phenobarbital protocols for acute alcohol withdrawal and the use of lenacapavir. And do you have any strategies to screen or mitigate these going forward?
I think that's also an excellent question, and we might have a case about that coming up later in the day. I think it's easier for known medications that might interact that you could either the patient's taking or might anticipate that they would take, but there will be situations when patients need a medication and then they already have the lenacapavir in their system. So I don't have a great answer for that, but it's definitely something that could be concerning, and thinking about strategies and ways to kind of get around by altering whatever you're treating, with the drug that's interacting with the lenacapavir to see what alternatives there are. But I think it's really, really important, and I don't have a great solution or answer for that.
And the next question, I know you presented data from clinical trials, but do you have thoughts on yourself on adding lenacapavir to participants or patients with partial compliance or partial virologic control?
Yeah, I think it's a great question that needs to be studied, and I think the case series of using CAB and LEN together kind of is what came out of that case series was a call for a trial to look at this at our center when we have used, and again, this I want to highlight, this is very much off-label, but for patients where we are worried about NNRTI resistance and they had very high viral loads, let me back up. For patients that don't have NNRTI resistance, where in theory you could use cabrylpivirine and that would be effective, but they had very high viral loads. We were worried about adherence. Maybe we didn't have all of the resistance testing. We have, in very select cases, and this very much off-label, but added lenacapavir to cabrylpivirine until they got lower, undetectable, and then maintain them on cabrylpivirine. But that's something that's just, it's very much unstudied, and so totally data-free zone and just sort of based on our worry about kind of how those individuals are going to do.
And then going back to your comments on weight gain, does the lack of benefit in the switch studies that you cited suggest that INSTIs are not causing weight gain, or that the weight gain is permanent once you start on INSTIs?
I wish I knew the answer to that question, and I don't, and I don't know that anybody does. There's a really great perspective piece and kind of systematic review in CID that kind of called into question how much are INSTIs contributing to weight, and looking at data from PrEP studies as well as looking at the obesity epidemic and weight gain in the general population and sort of how to tease all of these out. I think, I think it's a shift, a moving target in terms of how much those are contributing. I think the thing that I do feel confident in is that switching off of a really good antiretroviral regimen is probably not the thing to do, because you're putting virologic control at risk, and it's probably not going to benefit weight. But I think there are now, luckily, there are newer ways and more effective ways that we can start to address weight gain and obesity that are probably, more where I'm going to put my money than like thinking about tinkering with the antiretrovirals. But it's an excellent question that's very perplexing.
And maybe we'll pose that question to our expert speaker this afternoon, so get her thoughts on this particular issue. I think that's all of the questions that have come in, and I think we're just about on time. So unless there are some last-minute questions from the audience, I think we'll ask our next speaker to come up and thank Dr. Wooten for an excellent presentation.